And we welcome you to MedStar Health, Rise of Robotics and Orthopedic Surgery, a live forum streaming from MedStar Union Memorial Hospital, where you're about to hear from and talk to 6 MedStar Health orthopedic experts about the use of robotic technology in surgery and research. And thank you for joining us tonight. I'm your host, Jaime Costello from WMAR 2 News. Listen, I don't care if your back is barking, or you're like Shakira and your hips don't lie, or your knee is sore going up and down the steps. This is the place to be tonight. So we want you to stay very close. If you've got questions, we want you to post them right now in the comment sections right there on the platform that you're watching us from, whether it's the MedStar Health digital team. They are monitoring both Facebook and YouTube. So now's your chance to get those answers in real time. Don't forget to share the live stream to your own page so your friends and family can watch us too. And here they are, the great team with more than 100, make that 200 years of combined orthopedic experience. And let's meet the team right now. First up, Dr. Paul Asdorian. He is the attending spine surgeon here at MedStar Union Memorial, a pioneer in the use of robotics for spine surgery in the MedStar Health system. And for more than 35 years, this good doctor has utilized state-of-the-art techniques in diagnosis and treatment of decompressions and fusions. Good to have the doctor with us tonight. Dr. Bradley Moats, he is the attending spine surgeon whose clinical specialty really includes spinal stenosis and degenerative spine conditions. And he's on the forefront of augmented technology here for spine surgery. And we're going to be hearing more from him about that coming up in just a couple of moments. Next up is Dr. Henry Boucher. He is a nationally recognized expert when it comes to hip and knee joint replacement, specializing in robotics. And he's also the physician executive director of MedStar Orthopedic Institute here in Baltimore and the chairman of the orthopedics at MedStar Union Memorial Hospital. Dr. Boucher, welcome. Dr. Mark Hausnauer is specializing in primary, partial, and revision knee and hip replacements. And he has a special expertise in anterior total hip replacement using computer navigation and robotic-assisted joint replacement. We're going to hear from him in a moment. And Dr. David Gold is right here, the chairman of the Department of Orthopedics for MedStar Franklin Square, and he specializes in sports medicine and both computer-assisted and traditional hip and knee replacements. And Dr. Gold also performs fracture care and general orthopedic surgery. Let's go all the way up to the 6th floor now to meet Dr. Brian Cunningham, a Hereford Bull. He is the director of the MedStar Health Muscular, the Education and Research Institute here, and there he is in the Division of Orthopedic Research right now in the Department of Orthopedic Surgery here at MedStar Union Memorial Hospital. We'll be getting back upstairs to Dr. Cunningham in that research space, and wait until you see what he has for us here tonight. Let me take you back a couple years ago. In 2017, right after it was approved by the FDA, Dr. Henry Boucher used robotic and assisted technology to perform the first ever total replacement in the state right here at MedStar Union Memorial Hospital. And since then, dozens of robotics trained surgeons from MedStar Health System have used the technology to replace thousands of joints. Let's go to the doctor right now. Doctor, at the time you were doing this, did you think you were onto something? I mean, was this what were you thinking when you were starting to do this?
Well, we've been watching the technology for many years, even before the newest generation of robotics came out. And so the platform was expanding. And once it reached a critical mass where the robots could do multiple things, we jumped in. And my opinion was that it was going to be something special, that patients would demand it, and that surgeons would be able to do their job better. And then I thought that because we're experts at what we do here, that we needed to have expertise in this type of surgery.
As a human, what was it like putting it in the hands of a robot?
So people think that we're sitting in the back room drinking coffee when we're doing this, and that's not the case. We are still doing this surgery right next to the patient. You'll see some videos coming up, and my colleagues will walk you through sort of the specifics of how we do these surgeries. But the robot is a very special tool to help us do this surgery better, and I believe it does. You know, there are some caveats. There's some debate about how much does this actually improve the patient after? And the short term, if you look at orthopedic literature, may not show much different, but we're in this for the long run. We want to do these joint replacements, these spine surgeries, and we want them to last, right? We want them to last people's lifetime, hopefully, and not have to have them redone. And one of the reasons they're redone is because sometimes they're not put in as perfectly as possible. So I think the robotics helps us to get closer to that. And that's what I think makes it special. And I think any patient who's considering this type of surgery, when they know that this technology exists, there's no reason they wouldn't opt for it, because they know it's going to make their surgery more accurate. We know that it does that.
Take us down the road. What do you see down the road?
So you're going to hear some other technologies besides robotics tonight. Dr. Motes is going to share something with us that I think is going to actually come into the next generation and probably link to robots as well. But the whole virtual reality, augmented reality world is going to grow. And so here at MedStar, we love technology. We love to employ that in our practices. I think we've demonstrated that over the past 5 years. We've gone from one robot to now we have 5 in the hospital and an extra one out in our surgery center. So sort of wherever we do our surgeries, we have this technology. So the growth, it'll be a different platform. And now you'll see that there's many competitors in the marketplace making robots and making new technology. So just like you see with cell phones or anything else where there's, if you look back in the 80s, you saw those enormous phones and how over the next 20 years, how much that changed. You're going to see an explosion in technology that helps us do our job.
Yeah, it's like the new model of the car. You wait a year. What has transpired since that first case? How's the robot improved?
So, well, we have more of them.
Yeah.
We also have different brands. So they achieve their goals sort of in a similar way. So the protocol might be a little different and the tools you use might be a little bit different, but the goals are the same. And they really help you to customize the surgery for a patient, is to take their particular anatomy and put things where they're supposed to be. Whereas in the past, if we use, say, standard instruments to do this surgery, then you're using averages to align somebody. And then you might be releasing ligaments. Well, the robot helps us to really advance plan the surgery and customize it for the patient. So I think that's a huge benefit. And so we've gone from 1 to, like I said, 6 robots in that past 5 years. At this point, all my knee replacements are robotic assisted.
No kidding. Mm-hmm. And there's more options for hip and knee replacements now, right?
Correct. And my colleagues are going to show you that tonight for sure.
All right, let's get into Dr. Mark. Let's talk about that. The hip and knee, the options that are out there now facing us when we've got the pain. We come to see you, then what do you tell us?
So I think Dr. Boucher highlighted everything very nicely. At the most basic form, these are tools that allow us to be better at our jobs, right? So we're more accurate, we're more precise, and we can really do a more patient-specific type of surgery that hopefully leads to a quicker recovery, better outcomes, and better long-term outcome for our patients. So we have several options here at MedStar. The 2 robots that we've utilized, both the ROSA and the Mako, are 2 options that are widely used on the market. Again, they have a little bit of differences, and there are differences in how they're used, preoperative planning, and things like that. But the important thing is that our team here is very well versed in using them and using them well.
And tell us about the technology of the ROSA, and what was the other one?
The Mako. There's actually a video being shown here of that robot being utilized for a hip replacement. What we use is a preoperative CT scan. That's the main difference between the 2, or one of the main differences, is that we obtain a preoperative CT scan where we make a plan for the case. We then take some intraoperative landmarks and then execute that plan for each patient on a patient-by-patient specific basis. At the end of the day, they're both very helpful tools that allow us to be more accurate and more precise and hopefully provide us with better long-term outcomes than we could in the past.
And those that are streaming live with us right now, they want to know, how long does this take? Does it speed up the process and the healing process?
That's the hope. I would say on the average case, it does not add much time at all. If anything, it's relatively time neutral, so it doesn't really change much. Another exciting technology we've been using here at MedStar is the VELYS hip navigation. So this is a little bit different in that it's not a robot, it doesn't have a robotic arm. It's based purely off of imaging we obtain inside the case. And we actually have a video, we can show this in a live surgery and how it's utilized and why we're excited about it.
All right, let's take a look at this. We want to see what Dr. Mark is really doing behind the curtain right now, the magic that he's performing here at MedStar.
So this is a patient who came to see me in clinic. This is a patient who has severe right hip arthritis. He has bone-on-bone wear with complete loss of cartilage in the hip. As a result, that right hip has shortened and lost what we call offset, or distance away from the pelvis of the femur. Restoring both of these is very important for the long-term outcome and function of that hip. So in the case, we take several x-rays beforehand, and our specially trained representative from the company is making special alignment and measurements for the patient. As we know, each patient is a little bit different, has different anatomy and things like that. So they take their time and achieve the appropriate landmarks and points inside the case. So we will use these measurements later in the case, which we will show you. And while we're doing this, we are still performing the case and working in the operating room. So there's no real change in time for us in the case, and it doesn't change our workflow at any point. So the first portion of the case is we are putting in the cup, or the acetabular component, in the socket of the hip. So you'll see here in just a second, we're using a specialized impaction device under live x-ray. So here we are putting that part inside the pelvis. We take several x-rays as we're working in order to align that part down to our specific target degree. So what we're looking at here is we're trying to achieve a target goal that we're able to change on a patient-by-patient specific basis. And with these measurements, you'll see us impacting this cup in place. So if you watch here on the x-ray on the left, we'll take serial x-rays as we place this cup in the appropriate position. You can see it being impacted into place. You can see it going down there. And with each change in position, we then re-verify that it's in the appropriate alignment. The alignment of this is very important for long-term outcomes. It's important for stability and the overall function of the joint, so we spend a lot of time making sure we get this exactly correct and where we want it. Once it's confirmed and then seated in the appropriate position, we take one final x-ray, and then we then move forward with the case. You'll see here in just a second when we take our final x-ray, confirming that it's in the appropriate position. Here the rep is just confirming the alignment and the position. We're happy with how it looks. We're putting the final liner in the cup, and there we take our last x-ray with everything in place. We're happy with the position, and we then continue moving forward with the case. So the next part here, we then work on preparing the femur using that same specialized impaction device while we're getting the software ready to go. So here you'll see us preparing the part that goes in the femur, or the stem. And once we achieve the appropriate position and size, we then put that trial in. So here we are preparing the femur, getting the stem in the appropriate position and size. And once that's fit and appropriate, we then place that trial in and put everything back together. So that's with that trial part in the femur. We then use that x-ray and then directly compare it to the x-ray from before the case. And with this software, we're able to measure it down to the millimeter in terms of change in position from before the case. And as we talked about, this is really critical for restoring the patient's anatomy, leg length, and overall function of the joint. Here's the final x-ray demonstrating the final change in measurement. We were able to restore the leg length and the change in position away from the pelvis down to the millimeter that was symmetric to the other side. The patient did very well post-operatively. The patient was discharged home the same day of surgery and was back on his couch early in the afternoon.
Amazing. You described that like putting a Ring doorbell on your front door. That was great. Thank you for leading us through that. That is incredible. Are you even amazed at the technology? Seriously.
I think it's pretty interesting. You know, you look at the course of joint replacements over the last 30 or 40 years. Before, it used to be a 4-hour surgery, a 7-day stay in the hospital. Now a large percentage of our patients are going home the same day, and leaving pretty quickly and doing very well.
Okay, I'm going to run a stat here about knee replacements, but first off, how do you know? I'm going to open it up to anybody who can. How do you know you need a knee replacement? All right, you're having trouble getting out of a car. Maybe you're having trouble, getting out of bed in the morning. How do you know it's time to get the darn knee replaced? Anybody can answer that?
I'll take that one. You know, lots and lots of people have arthritis in their knee. When it gets to the point, and when I tell our patients, when it interferes with your everyday ability to enjoy things. You can't chase the grandchildren anymore. You can't go out for a hike. Every time you walk, it hurts. Your knee swells, it's stiff. You've tried all the non-surgical things, medicines and sometimes injections, and at that point it's probably worthwhile to at least get a surgical consultation and to see if you are a good candidate to have a joint replacement.
All right, Dr. Gold, that's good. Here's one from Tony, who's watching us now. Tony says he has bone on bone. Are these robotic techniques an option for Mr. Tony?
Absolutely. That's why we do joint replacements, is for bone on bone. When you don't have any cartilage left, any cushion left in the joint, and that's when it is bone on bone. I do all my knee replacements with robotic assistance now, and so absolutely would be a candidate for a robotic assisted knee replacement.
All right, Tony, we'll see you tomorrow here. All right, knee replacements, surprising numbers here. I want to run this down because this is very important. The American Academy of Orthopedic Surgeons, by 2030, which is right around the corner, total knee replacement surgeries will grow almost 700% to 5.5 million procedures a year. And that's half of all American adults will develop arthritis in at least one knee in their lifetime. So are we seeing right now a rise in knee replacement? I guess we are. I mean, we're starting to see the surge, right?
I honestly, I don't think that number is accurate.
Oh, it's not. Well, that's good.
That's a incredibly quoted paper that was out probably, 5 or so years ago, 10 years ago, that talked about this massive boom. And so, yes, the numbers are going up, but 700%, I think that's an overestimate. I don't think we've seen that since that paper has come out.
Okay.
So, it's probably 5 or 10%. There's a whole bunch of reasons why. We had COVID and people weren't getting surgery during COVID. So that knocks that number back because our volumes were less, across the country. But there's about 1 million knee replacements going on every year in this country. And so I don't think we're going to see that goes up another 5 to 7 times in the next 7 years. So, maybe 50%, I would say. I mean, you guys agree?
I think the numbers are going up because people are demanding more of their bodies. People are less willing to kind of just wait. People want to go now. And if there's something that they can have done that's going to allow them to be more active. I think from the technical standpoint, what we're talking about tonight is allowing us to do joints that hopefully will hold up longer, last longer. I mean, we used to get very, very worried about doing a joint replacement on someone maybe even in their 50s because we didn't think that they were going to last more than 15 years. And I think that number has really gone out to 20, 25, maybe 30 years. And I think technology, not only in how we do the surgery, but what the implants are made of, has really expanded the ability to treat younger people.
How about when people come to you for a sore knee, banged up knee? Oh, it's aching. Are they surprised with the robotics when you present the robotics, the rise of robotics? And what should they expect with knee surgery, knee replacement?
So when I always tell people about the robotics, and most people say, hey, that's cool, that's really interesting, that's exciting. I think people love tech in general. Everybody wants to have the latest iPhone, device. But the bottom line is if we have a new tool that's making us a better surgeon, then why shouldn't we use it? I think what I do emphasize to them, as Mark and Henry said, is that I'm still doing the surgery. It's not taking the place of me. It's making me a better surgeon. It's actually making me have to think more because we get so much information from the robot and the computer that it's attached to that there's many more calculations so that I can just be a more accurate, more precise surgeon.
Do we have an option, whether we go human or robotic?
Always. We don't have to go to robot. I mean, still the vast majority of joint replacements that are done in this country are not robotic. I think at MedStar we're a bit ahead of that curve. I think there's a transition to that as you see more and more younger guys like Mark come out. I mean, they're all going to be trained in robotics. because that is definitely the way of the future.
All right, Dr. Gold made a video here. This is very nice homemade video here. He's going to show us the importance of knee replacement surgery. Is that correct?
I'm going to show you the robot that I use.
Very good. Name? Does the robot have a name?
She does. Her name is Rosa. I'm not sure why we call it her, probably because she's very efficient, she's very precise, she's very accurate. But we can roll the video. I sort of talk through it for the most part. I've been using the Rosa robot for about 2 years now. Before that, I did something called computer navigation, which was also very technical. But this is computer navigation on steroids. So I'll let it play out.
A knee model here. We have the Rosa robot who she stands next to me during the surgery. There's some computer screens that give me a lot of information throughout the procedure. Typically we'll have the x-rays up that show the arthritic knee, which I will reference during the procedure. And then there's a camera, an infrared camera, that is taking pictures and is picking up the signal from these arrays that are located on the femur, on the tibia, and there's also an array on the robotic arm itself. And that's where all the data is being incorporated into the computer system. So this is the robot going through a calibrating step. It's going through a series of maneuvers to make sure that everything is programmed properly. And this robotic arm is what we're going to use to help us guide through the surgery, as you're going to see. And once it goes through this series of steps, we'll be removing this piece, this array, and we'll be putting what we call the cutting guide on the robot, and we'll use that for the rest of the procedure. So once that's in place, then what we would do is we would choose different points throughout the thigh bone and the tibia. And what that would do would be to allow the robotic computer to formulate a model of the knee. This is one of the other tools that we would use. These arrays are being picked up by the infrared camera. And then once we've located all these points, we will get to a screen that would tell us what the deformity of the leg is in the beginning. It would tell us how tight the knee was on certain areas. And then I could essentially do manipulation of these numbers on the computer, and I can essentially do the operation on the computer screen before I've ever done anything with the knee. The advantage of that is I can play out the entire operation. If there's some things that I want to change, I can change it on the screen, and then once I get the plan set, essentially I've done all the surgery, and the rest of the surgery is going to be just simple manual labor. There's a lot of numbers, a lot of calculations, there's a lot of geometry involved. But I can position and change a lot of different things on this screen to try to create as perfect a knee as possible. So now I've developed my plan in the Rosa system, and the robotic arm is now going to swing into the field. And you can see how it knows exactly where the bone is, and it's going to come into view, and it's going to come into its perfect position. And then the last step is I manually assist it down to the bone, and then I would secure it into place with 2 pins. And it has a cutting slot here that allows me to cut, and this gives me a perfect cut on the end of the bone. And then once I make the cut, I can then check the cut. If it's off even 1 millimeter or 1 degree, I can correct it if I feel that that's important. Doing a good knee replacement is all about balancing the knee, making sure that the ligaments are equally tight on one side of the knee versus the other. The most effective and the best outcome of a knee replacement is one that has the best range of motion that you can achieve and is balanced from a ligament standpoint, which means the knee is just as tight on the one side. This is a model, of course, but we have ligaments, and they have to be balanced appropriately. So this is the last motion that we need from the robot. The robot is now setting the rotation of the femur, and it's going to allow us to make some fine adjustments, again, to best balance the knee. We'd be checking the knee, how far it straightens. We would be checking the alignment. We would check the stability of the knee. And the robot would give us all that information. You can see as I'm checking the stability, the robotic eye is essentially calculating that. And I'm using all that information again to give the most accurate knee replacement that I can.
Outstanding. Dr. Gold, man, you're up for an Academy Award. Outstanding.
The best thing about Rosa,
Yeah.
she never calls in sick.
She didn't talk back to you either, did she?
She does not, and she doesn't take a lunch break.
That's great. And see,
so she's always very helpful.
You fought taking geometry in school, didn't you? See, it helped.
In orthopedics, geometry is critical for us.
That is
Spine
great.
surgery as well. It is one of the main sciences that we do use all the time.
All right, people are chiming in right now. They want to know. How about Carolyn C., who's from Baltimore, posted this on Facebook. I had shots in both of my knees about 8 months ago. The pain stopped after about 3 weeks, but I'm trying to deal with the pain now. Would this robotic navigation help? Would it help her?
I would say that if you're a candidate for a joint replacement, you're certainly a candidate for a robotic-assisted joint replacement. So as Dr. Gold had mentioned earlier, once you've tried and failed all the appropriate non-operative measures, and you're certainly limited on a day-to-day basis, and the things you like to do, you want to do, and need to do, then it's certainly worth having a discussion about a robotic-assisted joint replacement.
Very good. Here's Carla, who has also been doing her research on the robotic options, but there are so many. The Rosa is just one option. How does she know who to trust?
Go ahead. I'll take that one. I think that you would do it the same way you would figure out how to trust any physician you're seeing. So you develop a relationship, you are comfortable with the bedside manner, and then I think it's a legitimate question to ask how experienced somebody is, whether they're doing manual knee replacements or robotic assisted. So you want to know how long have they been using it? Have they had any particular problems? Why do they like the one that they use? So it's the same questions you would get when you're really vetting whether you want to trust a particular surgeon to do your surgery.
All right. Notice all these doctors are sitting up nice and square, great posture, and that brings to us the spine. So let's take a look at this space, folks. This is up on the 6th floor here on 33rd Street building, where we're about to talk with Dr. Brian Cunningham about what testing happens here in the MedStar Musculoskeletal Education and Research Institute. Anyone who has ever had orthopedic surgery will be glad to know that every procedure, every implant, every screw gets tested. We have a camera upstairs now. Let's go for a live look at the center and talk to Dr. Cunningham about this. Dr. Cunningham, can you show us around and tell us all the data you are collecting?
Hi, Jaime. Good evening. Thank you for being here. We are delighted to have you here, and we're delighted to have you in the Musculoskeletal Research Center, and more specifically, the Orthopedic Biomechanics Laboratory. We have lots of core areas of research capability here, but currently we're standing next to our test machine in which we evaluate some of the implants that you've just seen in the clinical setting. We test these in the biomechanical laboratory. There were a number of very good points that came up during the clinical presentation. I jotted these down as I heard them come through. Terms like alignment, position, stability, size, function, best range of motion, material composition, accuracy. All of these types of questions can be answered in the laboratory setting. And this is an example of a couple of things here I'd like to show you. The first, in terms of an implant that maybe many of the viewers have not seen, is a total knee replacement. So one of the questions that a clinician may have is, what is the functionality of a knee replacement? If we were to take this knee and implant it in its best possible position, or maybe in a suboptimal position, how does that affect the range of motion of that knee? That type of question can be answered here, and I'll be explaining that in just a second. Likewise, in total disc replacement, now this is in the lumbar spine, a similar question could be asked. Here we have a disc replacement that's more or less optimally placed and allows for motion to occur in the lumbar spine. But the question may come as, what happens if this disc replacement is suboptimally placed, not ideal positioned, undersized? How does that affect the range of motion that occurs in this motion segment or operative segment? And as we're going to switch gears here just a little bit, in the case of a fusion construct, and I'm sure most of our viewers have heard of spinal fusion, where rods and screws are implanted. Now this happens to be an acrylic model, a sawbone model with pedicle screw and rod instrumentation. And we can put this in the simulator, which I'm going to show you in a second, and we can move it around. And grossly, you can tell that as I move this, the portion that has instrumentation in it, and this instrumentation looks something like this, that can be viewed, screws and rods are placed in the spine to augment a fusion. So they're temporarily in place while a fusion takes place. But you can appreciate that the levels which are instrumented are not moving as much as those which are not instrumented. So these types of properties in the spine, be it in a fusion model or one that preserves motion, such as a disc replacement, can be answered through robotics and navigation in a laboratory setting. And I'll go ahead and explain that now. Much like you've heard in the operative clinical environment, we use a robot to apply motions to musculoskeletal structures. So we can take, now if you look over here, this is an acrylic model of a spine. We typically use donor tissue. That's cadaveric tissue. These are individuals that have donated their limbs or their organs to studies. So we're able to get cadaveric tissue, simulate or mock this setup as shown here, and then do reconstructions to the spine and evaluate different reconstruction techniques. I'm going to go ahead and run this machine, but before I do, I just wanted to show you the concept of it. The upper end, so this is a lumbopelvic model, which most of you can appreciate. These are the hips here. This is the lumbar spine. We can attach this. We have the capability through motors to drive it in different directions. And driving it in different directions, while we're doing that, we have markers placed on the vertebral elements. So that's the vertebral bodies as shown. So we're able to understand how much motion is occurring as we move the spine through, let's say, flexion and extension. So that's forward and backward bending, as well as lateral bending, as shown here. So we're going to go ahead and run this machine. we're going to drive it in flexion extension, and it'll give you an idea of the types of motions that occur and how we can quantify these motions and, in fact, address some of these questions or terms that came up earlier, for example, best range of motion. This spine right now is going in with an extension and now is moving into flexion. This is one piece. So this is our robotic platform. It's a little bit different than the robotic platforms that you saw in the operative clinical setting, where it helps position the patient as well as the instrument for placing the pedicle screws. Here we're evaluating what's happening downstream, if you will, of those reconstructed segments. This is going in flexion and extension. I'm sure that many of the viewers have heard of the SI joint, sacroiliac joint. This is viewed right here. So we can place these little blue markers which correspond to the fiducials that you heard about earlier that are placed at the time of surgery. And we can look at this SI joint and we can quantify that motion, which means we can get an understanding of how much motion is occurring between the sacrum and the pelvis or the L5 level. I'm going to move over here and I'm going to show you, this is one piece, this is the robotic piece of the system, but all of these markers that you see are putting out a light-emitting diode that's being picked up by a camera system. This camera system is the same system that's used in the operative clinical setting. We'll move over here. This camera system is typically a little bit higher in the clinical setting, and it's viewing the surgeon and the fiducials as well as the instruments and the implants as they're being placed. So it's viewing these systems, it's viewing the reconstruction, and in the clinical setting, of course, it's the placement of the implants. Here, it's the functionality of those implants, addressing position, range of motion, etc.
All right, Dr. Cunningham, I have no spine, but those that do, what do you do with the data that you collect?
So this data is very important. It's used to educate our attendings, so the attending surgeons that are there now. It's used to educate researchers who are in this field. It's used to educate our surgeons in training, our residents. And probably most importantly, it's used to educate patients that are in need of this implant technology. And the way that's disseminated is either through journal publications, for example, as shown here. These are available. You could read about different studies that are done looking at accuracy, range of motion, clinical as well as basic science. And there are also a number of society meetings, specialty society meetings, dedicated to disseminating this information so that folks like Dr. Boucher and Dr. Asdourian can take their experience of multiple patients and get it out to thousands.
All right, well, there's another robot that is lurking here at MedStar Union Memorial Hospital, studying the work of robotics benefits from robotics. Let's take a look at this, Doctor.
We are in the Biomechanics lab of MedStar Union Memorial Hospital, and we are looking at a big KUKA robotic arm. This robotic arm is typically used in automobile industry, but there are multiple reasons that make this a good asset for our Biomechanical Research Center. Using that 3D tracking camera, we can track the actual motion of the joint, and then we can do some math and ask the robot to exactly do that type of motion for us. We are looking at the stability of the knee joint at different flexion angles. We are repeating the test for several different surgical methods, and we collect the data for all of these conditions. And after we collect all the data, we can look at the results and see if any of the methods is performing better than the others. We have a cadaveric knee here that we are performing a biomechanical test. We are looking at the stability of the knee after going under different surgical methods. We are bringing the leg into several different flexion angles, and at each angle we would apply external rotation, and then we would measure how much torque it takes to perform that task. Then, having all of that data, we can compare different surgical methods and see which one more closely mimics the intact joint. Right now, Diamond is collecting data using that 3D tracking camera and looking at the intact knee and then transferring all of those data points into the coordinate frame of the robotic arm. And then Manaswini would run the robotic arm into several different flexion angles, and then at each of those angles he would apply an external torque to the knee, and we would record the data throughout all of this experiment. And then we would repeat this experiment for different surgical methods. Obviously, it's a big robotic arm and it can apply a lot of force. During daily activities, some of our joints can see up to 4 times our body weight. This robotic arm can apply up to 660 pounds of force. While it can apply that huge amount of force, it is also accurate. For any type of research study, you want to be accurate and repeatable. The accuracy of this robotic arm is about 2/1000 of an inch. And also it is programmable, so it's not limited to doing only one task. You can develop codes to have it perform different tasks. Right now we are testing the stability of the knee joint at several different flexion angles, and we are repeating the test for different surgical methods. Once we collect all of the data, we can compare different surgical methods to each other and see if any of them is showing better outcomes compared to the others.
All right, we'll lob this question to everybody who wants to answer. Kathy asks, do you ever disagree with what the robot is telling you?
I'll take that. Sometimes you do, and it's a great question. First of all, we are always there, and we're checking on things. But I would say 99 times out of 100, when my eye says something a little bit different than the robot is right, and I'm wrong. Which tells you that if you weren't using the robot, you probably would make maybe 99 small errors. So the robot is much more reproducible, but we are always there as a checking device. And I think maybe the other panels have the same feeling. The robot is usually right, even though it doesn't necessarily always look right. And I think that's important to show how the robot probably improves our surgical techniques, because our eye sometimes plays tricks on us.
How about that? All right, Dr. Astorian, the live stream, we'll see you now. We just wanted to give you a feel of what it's like to be in the waiting room. That's what, so now, here we go. 2019 is when he started this thing, when he led a team to become the first in the Mid-Atlantic region to use robotic GPS navigation to perform a lateral lumbar interbody fusion through a small incision. Why was this so significant?
Well, first of all, I have to apologize that my model is not as big as Brian's, so I have a little model envy. But, you know, as spine surgeons, we basically do two operations. We do a decompression where we free up the nerves that are being pinched or the spinal cord, and we do fusions of the spine for either arthritis or instabilities. And there are different approaches, and this model shows, it's a plexiglass model. It shows that there's the pedicle screws that Brian was showing in the lab at multiple levels that we put in from a posterior approach, meaning from the back. There's an anterior approach where you come in the front, and there's an approach where you come in through the side. And that's the lateral interbody fusion that we do. And when doing that, we have to use a lot of X-ray guidance to know where we're going, because we can't see the spine. We're going in through a muscle. And the uniqueness of the navigation is that it shows us exactly where we are in relation to the bony anatomy. So we know exactly where the disc is. We know exactly where to go into the muscle, where to spread the muscle so that the nerves are not being irritated. So we're staying away from the blood vessels because we have the major blood vessels that are in the front of the spine. So the robotic navigation really, as was mentioned earlier, allows us to do a lot of what we do more accurately with greater precision and greater safety. Everybody's anatomy is different, especially when you have a patient who is small. They may have small bones, and the bullseye for putting in the screws is smaller, or if they have had prior surgery and the anatomy is altered from the prior surgery. So the navigation really allows us to be more precise.
Unbelievable. So it's 1 o'clock in the morning and you're thinking, let's bring GPS into the hospital. I mean, how does that come to be?
Well, unfortunately, we only have one machine at the hospital, and you know, we do quite a bit of spine surgery. So sometimes there's an arm wrestle between us to decide who gets the robot. Dr. Motes was an arm wrestling champion, so I just pull rank on him. I'm older, so. But no, I think you can use robotics for every case, but most of the cases that are simple, straightforward cases, we use the old-fashioned freehand technique. But, you know, we're doing a lot of bigger cases, scoliosis, deformity, tumors, and in those situations where it's very critical to make sure that the instrumentation is placed just perfectly, I think the robot is essential, and it's really been a game changer for us.
Okay, explain the video that we're about to see that you put together.
Sure. So this is, just going to start, this is the monitor. So what we've already done is we've either obtained a preoperative CT scan similar to the joint surgeons, or we have now a 3D intraoperative CT scan. And what that does is it identifies the anatomy. So what we're doing now is we're planning our screws. So we're templating the screw placement, similar to the joint surgeons. The robot doesn't put the screws in, we do, but it allows us to put the screws exactly where we want to. So on the upper right-hand screen, that is a axial image of the spine, and the blue is the screw that's been placed, and the image right below that is the bullseye I was talking about. So if we run the video, we'll see where a screw is being placed, and now it's being fine-tuned, the placement exactly where we want it to go. We can determine the diameter of the screw based on the anatomy. Some people, we have the ability to put bigger screws in, and the length of the screw, because right in front of the spine are those big major blood vessels, so you don't want the screw to be too long. And now on the lower right-hand corner, he's going to be tapping that blue circle, so it's right smack in the middle of the bony structure we call the pedicle that we put the screw in. And as was said earlier, we do checks. So right now what I'm doing is I'm doing an intraoperative check, midline check, to make sure that what I'm seeing anatomically corresponds to the image. And now if everything checks out, now we do is we pick the screw, we step on a pedal, and then the robotic arm goes to the trajectory that we pre-planned. And then we manually will use different instruments and then place the screw into the different vertebrae. So what the robot is doing is putting our instruments in the exact precise position for optimum screw placement. And we did a study of 100 of major cases, over 1,000 screws that we placed, and not one screw had to be revised, which is a pretty incredible statistic.
No kidding.
On some of the toughest cases, scoliosis and that type of thing. So I'm a firm believer, and I've been putting.
Who's a good candidate for this, doctor?
Well, anybody's a candidate. Anytime a spinal fusion is done from a posterior approach, you're a candidate for robotic surgery. But as Henry was saying, there's a limited number of robots. We have one, so every patient can have it. So we try to prioritize the patients who would most be advantaged to have the robotic surgery.
All right, doctors, we got a question from Yolanda. Wants to know how much training is required in order to be proficient in robotic surgery. I think Yolanda's in med school right now. She's trying to figure it all out. So how much?
Well, all the surgeons who are doing spine surgery are taught to do what's called the freehand technique. So we know how to do the procedure without a robot. And the robot is actually easier because we don't have to use the surgeon's feel to make sure that the instruments are in the right position. So the training is pretty minimal, I think. The learning curve was pretty quick to be able to transition from regular spine surgery to robotic surgery.
All right, let's go to the arm wrestling champion of the world. Here he is, Brad Motz. Virtual reality and augmented reality really became a household word because of the gaming industry. So how did you bring that into our game? How did that happen?
So yes, this is the technology that's just on the horizon now. So augmented reality, okay, it's a highly accurate emerging technology that you can use for both open and also minimally invasive surgeries. And the surgeon utilizes a headset during the operation.
So you put that headset on for the first time. What did you think?
It's incredible. It's incredible.
Did you take it home and play with it?
I wish.
What do you see in that?
So some people get mixed up augmented reality versus virtual reality. So augmented reality, it enhances the real world setting, whereas virtual reality is completely virtual. This is augmented reality. And I believe there's a video that we can show to help explain this.
Oh my gosh, this is a game changer. I can see boy, that made a huge difference.
I think the augmented reality, I think the sky's the limit for it. It's very impressive.
This is awesome.
It's ahead of everybody else in the U.S.
It's amazing. Dead center in the pedicle. Complete faith in the system.
So first time using the system within easily 1 millimeter
accurate.
I'm telling you, it was too easy. It was too easy. That's my problem.
We can show patients and families, here's a smaller hole we can make now to be able to get down to your tumor.
Oh yeah, you're rocking. That's good.
That one went right where it's supposed to go. Feels pretty good. I mean, it's remarkable to get feedback from different angles.
I think Novorad is poised to become a game changer in this field.
And proof's in the pudding. They are all correct.
It's amazing.
Yeah.
My chicken.
Hey, might change my life. What's the difference between augmented and the virtual? Is there a difference?
Well, yeah. So augmented, again, you enhance the real world, as you see there. A surgeon will put on this helmet that projects a holographic image on the actual patient. So it's a mix of holographic image and actual patient. Whereas virtual reality is just completely virtual.
That is incredible. That is incredible. So when you started in med school, this wasn't even close to being on them.
No, this is still being developed now. It has recently been FDA approved, and we're in the process of getting it approved here in MedStar. But no training on it whatsoever.
And also you have the video here on spine surgery as we just ran it by. The spine surgery as we have the augmented. How far off the horizon is this technology, doctor?
Not very far off whatsoever. It's only a matter of a couple months, I think, that we'll be employing this here at MedStar. But ultimately, this technology, as you can see here, it gives the surgeon a better 3D understanding of the patient's anatomy. So with current technology, a surgeon will utilize maybe multiple x-rays to know where they are in space, or they might use what Dr. Dorian was showing, the screen that he will look at to know where he is in space, whereas this is the headset that you utilize. The potential benefits of this technology, again, it's highly accurate. It can minimize surgical times, decrease blood loss, and overall maybe perform surgeries through smaller and smaller incisions.
Why not? This is a great question. Here it is from Facebook. Have any of you undergone any of the surgeries we talked about, and are you willing to share your experiences? Anybody?
Well, I'll share my experience. I had a lumbar fusion performed about 5 years ago. This is before the robotic surgery, and it went well. So, spine surgery, I think, often gets a very bad reputation because people who are doing well don't complain. It's the people who are not doing well. And I think that if I had the option, I'd have opted for the robotic placement of screws, but it worked out well.
What about the patients that come to see you? Out of 10, how many go, I don't know about the robotics yet? How many would say? Well, they're all for it.
I've never had anyone
no kidding
say, "Oh, I don't want you to use the robot," because I explained to them,
right?
It's the same surgery with enhanced accuracy and enhanced precision. I don't know of any downside of using the robot. So I've never had anybody say no, thank you.
I will have you guys with customers tomorrow lined up. Sciatica. Is there any way we can? It looks like everybody's got a pain up there in the butt. How do we do that? Is that tied in any way to the hip? Is it tied in any way?
Well, sciatica is typically pressure on a nerve root. So when we employ this technology in the spine world, a lot of times we're using it for the screw and instrumentation. We can sometimes indirectly take the pressure off a nerve to relieve that with this, but that's primarily more of a disc pathology.
All right, because everybody thinks, oh, I got to get a hip. How about left or right hip? Should we get the whole hip replaced, or or one at a time? The left or the right? Should we get it all done at one time?
Well, you can. You can have bilateral hip surgery if you have severe end-stage arthritis of both hips. I mean, I've done that a number of times. Most people, and that's a personal choice for the patient. So number one, they have to have the disease of both joints and have failed conservative measures like we've talked about. Medications, activity modification, physical therapy, sometimes injections. And you'll see some folks who really can't get around well at all. And so for them, and they're relatively healthy, so they can handle the nature of a bilateral hip surgery. Hip surgery traditionally considered a bloody surgery, even though I think our transfusion rates are now like less than 1% with how we do them. But still, it's anytime you're doing both sides at the same time, you're elevating risk. So the patients typically need to be healthy, and certainly you want them to be part of that decision making.
And here you go. If this is Karen, if you have knee and hip issues, should you have the knee replaced? Is that right? If you have knee and hip issues, should you replace before the knee, or should you have your hip replaced before the knee?
So I think they're asking which comes first.
Yeah.
I think that's on a patient-by-patient specific basis.
Yeah.
Typically, if all things are equal, we will discuss performing the hip replacement first, as it makes your rehab a little bit easier for your knee. But again, that's kind of between your evaluation, your imaging, so it takes a little bit of further discussion before we can make that decision.
Let's go, as Barbara's typing in here, let me go down the line here. Let's start with you, doctor. What are you most proud of?
My grandson?
He's got great hips, and he's got great knees. What are you most proud of?
I'm most proud of, I'm blessed that I've had a 35-year practice of spine surgery that, 3 decades of amazing advancements in technology. And I mean, I was the first one to put a pedicle screw with the old-fashioned technique at Union in 1987. And I was the first one to put a robotic screw in. So I'm just proud of the fact that I work in an institution that allows me to have the latest in technology so that I can continue to be excited about my profession.
And doctor, what are you most proud of? I mean, the future, unbelievable.
Yeah, it's very exciting. I mean, the reason that I got into medicine as a field was to help people, obviously. So, being able to see my postoperative patients in the office and they tell me, look me straight in the eye and say, I changed their life for the better. They're able to do things that they weren't able to do for years and years beforehand. That's the most rewarding part of the job.
Dr. Boucher, what's it like to take pain away?
Oh, it's so gratifying. I mean, that's what makes our job incredible, is that, it's hard to spend a lot of time with patients these days because we're all under pressure, time pressures, and we may not be able to spend as much time as we want. But when we take someone who comes in who can barely walk, and the next time we see them 4 weeks later after their surgery, they come in walking, their pain is maybe not completely gone, but they see the light and they're in tears. And I've had some burly guys that have this reaction, and they want to give you a hug. And, how does it get better than that?
Nothing. How about Barbara asking, how long do joint replacements last? Dr. Mark, fill us in. How long? Give us a...
So as Dr. Gold had mentioned earlier, we've made a lot of strides in terms of the survivorship of these joints. Traditionally, we used to be worried 10, 15 years. With the new parts, technologies, and ways we're doing these surgeries, these are hopefully 20, 25 plus year replacements that are working well and giving our patients a good outcome. And
Dr. Gold, just step back for a second and see what you're doing here at MedStar. Does it get to you?
I mean, it does. I mean, I've had a 30-year career, and when I think back to what we were doing, in the late 80s and now in 2023, the technology is it's just amazing what we can do. And the result of that is patients are able to get back and play with their grandkids. They're able to go out and dance at their daughter's wedding, and that is why we do this. But there's still a subset of our patients that don't love their joint. And that's what we're all really trying to work on. We're trying to figure out that small percentage of patients that are somewhat unhappy. And that's what this technology boom and why we strive every day to try to get better. Because it's not perfect surgery. There are things that we do that sometimes patients don't love. That's never what we want. So we're always striving to get better. And that's what we're doing here at MedStar.
And we're talking about the spine. Mom used to say, sit up, stand up straight, shoulders back. Can we improve our posture at 30, 40, 50 years old, or is it done?
I'll let you answer that one, Brad.
Well, I think to a degree you can, but the natural aging process of the spine is that we gradually will tend to fall forward. And there's There's nothing that we can do about that. We can't stop aging. But there is with physical therapy, working on our musculature. There's also surgeries that can correct posture as well. It can be corrected to a degree.
Okay, and Nina has questions about the medication, about anesthesia, and what's best over-the-counter medications for pain. I mean, that's all. That's patient to you. You're going to tell them what they need, right? Tell them exactly what it is. When they come out of it, what do you prescribe?
After their joint replacement, I mean, there's been a lot of advances in anesthesia to make the experience better. Most of our patients now receive some type of anesthesia block that helps with postoperative pain. We do really try to limit narcotics afterwards as much as possible because they have a lot of side effects. So there's a lot of technology in anesthesia and pain relief that we incorporate as well.
Let me ask you real quick. I know you all, the studies, the surveys, and all that stuff. From someone who has the pain of a knee or a hip, how long does it take them really to make the decision, I need help? Is there a study out there that says, 5 years, or people have grappled with it? Or what is the deciding factor to get in to see one of you?
I mean, there's so many decisions. I see some people that have the God worst awful joint, and you go, how have you been living that for 5 years? And we all see that patient. And then you have somebody who doesn't really have a terrible looking joint, and they're complaining and complaining and complaining. So I think patients are so different.
Yeah.
And, we try to evaluate each different situation. Sometimes that person that comes in with that absolute horrible joint that's been living with it for 5 or 10 years, I think that's the patient that we want even more because we can help them more.
Yeah.
But everybody has a different threshold of when they say uncle, and that's really what it comes down to.
Well, thank you, gentlemen, for an outstanding night of telling us and opening our eyes. If you're looking for orthopedic care right near you, MedStar Health has experts here in Maryland, Virginia, D.C., including specialized care like the Curtis National Hand Center right here in this building. MedStar Orthopedic Institute has the experts and the expertise that you need to so close to where you live, where you work. You can make an appointment at any of our 34 locations or schedule a video visit from the comfort of your very own home. Keep the questions coming. We will make sure all of your questions get answered. And this webcast is being recorded, and you can find it after the broadcast right here on Facebook and the MedStar Health YouTube channel. Thank you, panel. You were expert. You're great. And thank you for watching at home. Thank you. Have a good night.